Well, I guess we can go ahead and get started. I'm sure there may be some more people who kind of hop on as they're able to. Um, I did want to, before we get started, put a plug in that we do still have our May 6th and our September webinars open for anybody who's interested in presenting, or if you have ideas of someone who might be interested, please send those ideas our way. We're looking to fill those slots. And we did notice, luckily Reed noticed for us that we scheduled the September 2nd one on Labor Day. So we're going to switch that to September 9th instead. So that'll be in the that'll be updated in the next email. So if you have any interest in presenting on something, or if you know someone who might be interested, please send those either my way or Emily Gagan. And we can reach out to them and get things scheduled. And so we'll go ahead and get started. Today we have Simone Cheli with us to talk about treatment of schizotypy. So you can go ahead and get started whenever you're ready.
Okay, thanks, Kelsey. So, morning, good evening, whatever, to everyone. Nice to meet you all. So the idea of this webinar was to summarize a book that Paul Lysaker and I had edited during the last year. And so I always have mixed feeling when I talk about that, because obviously it recalls me how much we all miss Paul. On the other hand, I'm happy that we have worked together in the last year on this topic, and then we finally got this paper out. And so I have to say that the book started with a few observations that we were sharing and discussing about this idea that somehow on the topic on schizotypy or schizotypy, depends, I have heard different pronunciations. The idea was that it's a topic that I'm gonna to summarize a bit, standard definition of, but it's a topic that have been discussed many times in terms of research, psychosocial outcomes, neurophysiological correlators, and so on, and all this vast and sophisticated literature on schizotypy has been somehow always far away from clinical practice. And for a while, Paul and I have discussed about these strange characteristics of these topics and the literature about. And so we started with the idea of why we don't find a way to publish a very first book, because it has been the very first book on how to conceptualize and treat the clinical manifestations of schizotypy. Because if you open any search engine and look for books on schizotypy, you will find only a few amazing books, by the way, but they are all focused on research. And there is only maybe on a book published by Rain 20 years, more than 20 years ago, they were referring just a bit about assessment and just a few small indications, just one chapter about pharmacological treatment and some suggestion about psychotherapy or psychosocial intervention. So we were discussing at the same time about how much the work and the practice of authors of almost 1 century ago, that is scholars such as Harris Sullivan, Frida von Reichmann, but also William Fairbairn and so on, were taking for granted 1 century ago that It's possible to work with people with severe manifestations, schizotypes, such as schizophrenia, and recovery also is possible. But when we talk sometimes during training or even congresses, it doesn't seem so clear, so taken for granted that it's possible. So it seems that, again, this topic is more related to the idea of researching or looking for predictor risk factors and so on. And basically, this has been always the way, the focus of the many papers and books published about schizotypy. So Paul and I, so we're discussing about this idea, and so we decided to formulate an hypothesis about a few possible main transdiagnostic factors that we were suggesting may have been the milestones, the cornerstones of a conceptualization of schizotypy from a clinical point of view, and then a way to orient, inform the intervention. So before going on, maybe I don't know much you're familiar with the literature on schizotypy, but maybe a general definition might be of help. So when we talk about schizotypy, in spite of having different definitions, but we refer to the idea of a continuum ranging from subclinical or even healthy manifestation to extremely severe manifestation, psychopathological manifestation, ranging from schizotypal personality disorder, for someone, broadly speaking, all the cluster A personality disorders, and schizophrenia and psychosis. So the idea would be that there is this sort of organization of personality that represent a few latent traits that will be correlated for an heightened risk for schizophrenia and psychosis, and also other less severe manifestation. So again, this has been studied mostly in terms of what are the risk factors for a later manifestation of schizophrenia. And this idea can be traced back to early study by Bloiler 1 century ago. So because Bloiler and other scholars were noticing how healthy relatives of those diagnosed with schizophrenia and those diagnosed with schizophrenia before the diagnosis were sharing certain traits, similar traits. And so this initial hypothesis was later discussed by authors such as Paul Mel and others, leading to the idea that, okay, there can be this continuum, this kind of organization, and somehow anticipating a more recent discussion about dimensional hierarchical approaches to psychopathology. So the idea that certain traits are not necessarily pathological per se, but they may represent a higher risk for certain forms of psychopathology. So, as I was saying, the majority of the books and the researches published have been focused on looking for collecting data about these measures, psychometric, neurophysiological, biological, and so on, measures that may relate this latent organizational personality with an heightened risk. In the book that we decided to work on, the idea was instead to try to transform all this knowledge in a way to identify a possible lines of intervention from conceptualization to treatment, focusing on psychosocial intervention. We included in the final version of the book just one chapter on clinical staging, so recalling some suggestions from a psychopharmacological point of view, but mostly we were focusing on psychotherapy, psychosocial intervention. So we organized our work and we invited several amazing scholars to discuss three main chapters. Three main sections. The first one was about the idea of presenting and discussing schizotypy as a broad general feature of personality and psychopathology. So sharing a ground for better understanding what we were talking about. We asked several authors to talk about. I will briefly summarize later this point. But again, the focus was not to discuss just theory or research, but sharing, summarizing evidence for supporting psychosocial intervention. The second section was an hypothesis that Paul and I have discussed. That is the idea that, okay, we don't have guidelines to treat this kind of manifestation, but we can suggest a few transdiagnostic factors. And this was for us extremely important and was coupled with the final section, the third section, where we present a few integrated interventions. Because the most recent survey and research suggests that people reporting this kind of organization might be something like 9% or 10 or even 10% or just a bit low of the general population. So we are talking about a huge subsample of people having these latent threats, and so having this potential risk for manifesting even severe manifestations such as psychosis. And it's quite strange that there is so limited investment in terms of research, and not only research, to develop and formulate guidelines to conceptualize and treat these manifestations, especially in the early phases. So if we consider schizotype as an organization personality, so this would imply that maybe we can detect and work on early manifestation before severe forms of psychopathology. If you look at literature, for example, one of the most used indicator and study on schizotypal personality disorder, outcomes is usually transition to psychosis, because we take for granted a high risk of this transition. So we have presented a very personal view of this topic. So in the sense that not necessarily the factor we have focused on are the only one. We thought that these were the most important, and there were those more related to intervention that had shown evidence in treating different manifestations related to schizotypy. And so in the first section, we discussed, as I was saying, the features. So the general features of schizotypy has been personality traits and an important element of psychopathology in the last century. And so we asked different authors to present the neurodevelopmental perspective, the evolutionary perspective. So another chapter about psychopathology, and so how schizotypy can be understood through the lens of modern approaches to psychopathology, psychosocial functioning, phenomenological perspective, and then psychometric and cross-cultural perspective. So by considering the focus on merge institute and so on, happy to say that a huge contribution has been made by people collaborating with Merit Institute. So for example, in the first section, the chapter on psychosocial functioning have been made by Kylie Minor and his group, and so I personally contributed with Martin Gruner on the chapter on evolutionary perspective and so on. So, what comes out from this first more general issue, more general section, is from my point of view the fact that there are multidisciplinary evidence suggesting how this organization is not just a theory, but it's consistent with several elements. And these elements suggest that there is a continuum between neurophysiological data, psychosocial functioning, and different aspects that have been discussed in psychopathology. So from more theoretical approach, from neurological approaches, and so on. And what is important to me is that both neurodevelopmental and, for example, evolutionary perspective are consistent with the idea that this is a latent threat, not necessarily a pathological one. So we are talking about something that has been related in some certain cases also with positive aspects. For example, we know that threats related to a higher risk for schizotypal manifestation is associated with open to experience, and in certain cases to a higher creativity. There is, for example, a huge study conducted in Sweden and Finland, where they present how healthy relatives of those diagnosed with different manifestations of schizotypy were reporting a high probability of working in creative jobs, arts, and so on. And so these and other elements were, again, consistent with this continuum. And from a clinical point of view, this is important. It's not just theory, because it supports the idea that we can help people rather than curing or negating certain aspect of themselves. We can instead try to help them finding more reliable, more viable, more adaptive way of use their threats in their daily life, and so finding a way to pursue their meaning of their life, not just we want to treat your maladaptive threats. So my personal approach when I work with people with this kind of manifestation is that we are not here to changing who you are. We are here to widening your strategies. That's possibly you have used certain strategies that were not that adaptive, and so adding, integrating new strategies may help you pursuing your goals in your life. In the second section, as I was mentioning, we follow these premises and invited several authors to present 5 main mechanisms, processes, factors, call whatever you prefer, that we think are consistent with this more theoretical background I was presenting before, and are the milestones, the cornerstones of an intervention, so from conceptualization to treatment. So the first chapter has been written by Paul himself and Courtney Wispete, about the perspective of metacognition and so a possible integrative application of the model of metacognition to the conceptualization and treatment of schizotypy. So not just psychosis and schizophrenia, but the wider organizational personality. And then we asked George Salaminios and Martin Debanet to present the mentalization perspective. So the perspective that was originally developed by Anthony Bateman, Peter Fonagy, and so on. So, and the application to the treatment for psychosis, schizophrenia, and also other manifestation of schizotypy. And here, an important role has been devoted to the link between the role of internalization and aspect related to attachment. Then in the next chapter, we ask Catherine Berry and her group to directly address the role of attachment and related processes in psychosis spectrum and so in schizophrenia. So discussing how early experiences, early development of internal working models and interpersonal schemas may influence and may increase the risk for this severe manifestation of schizophrenia, real schizotypy. And then we asked Paul Gilbert and the group of Harold Pincus to discuss the evolutionary perspective on compassion and the interpersonal perspective of contemporary integrity, interpersonal theory, respectively. So on the one hand, Paul Gilbert discussed how mechanism processes related to self-criticism, shame, and guilt may fuel a threat response that increases the risk for the manifestation of severe symptoms, such as those related to psychosis, schizophrenia, and so on. And then, on the other hand, Aaron Pincus and colleagues focus on the importance of interpersonal domain, broadly speaking, in terms of different interaction, different attempts of a person to struggle with our most relevant and challenging experience as human beings, that is, human relationships. So, in all this perspective of these 5 factors were partially related to one another, and all suggesting that there is evidence for a few important processes, mechanisms that may guide, may inform a conceptualization of many diverse diagnoses related to schizotypy. And so they are important in understanding why the person is manifesting in this phase of their life these symptoms, and how the symptoms are related to their difficulties, their attempt to struggle with the daily challenges, and so how we can start somehow validating this difficulty rather than contrasting or negating them, and so helping them to find more viable ways to cope with their challenges and difficulties. So in the last section, we present a very wide collection of different approaches, therapeutic approaches, so psychosocial treatments that we have thought they may have support those interests in helping people. They are very different and not necessarily consistent one another, unless we consider the very initial premises that they all share the idea that recovery is possible, and the subjective experience is the kickstart of any intervention. So when we talk about odd behaviors or even delusional experience, we are not talking about things that are without meaning. They are not consistent with the individual meaning or individual experience of the person that is usually called as passion. So in this third section, we present for sure metacognitive interpersonal therapy and merit itself. So to core intervention based on the idea of focusing, not exclusively, but mainly on the level of metacognition as a way to understand what the person is passing through and how to help them. So we thank Courtney, Ilanita Sono-Ion, and others to have concluded the chapter on metacognitive reflection and psychotherapy. The group of Giancarlo Di Maggio for the intervention for metacognitive interpersonal therapy. And in the former case, they present diverse intervention on diverse possible manifestation, whereas in the chapter by the Italian group of metacognitive interpersonal therapy, they focus just on schizotypal personality disorder. I presented also my work on schizotypy, that is a way to integrate the work on metacognition, mainly focus on Paul's perspective with the experiential techniques related to compassion-focused therapy. There have been also a specific chapter on compassion-focused therapy by Charles Elliott Maitland, and other chapter that refer to cognitive behavioral therapy by Douglas Starkington and colleagues. A chapter about mentalization-based treatment by Jeremy Ridenur and colleagues. And then there are other, another chapter about psychoanalysis by Andre Peck. And then finally, two chapters, not about, let's say, a specific psychosocial psychotherapy treatment, but more broadly, one discussing clinical staging of schizotypal disorders. So a few preliminary consideration about how we can try to develop a clinical staging understanding consistent with the work of Patrick McGorry, who was one of the authors. And finally, a chapter by Takahiro Kato, who was presenting the possible relation between schizotypy and severe forms of social withdrawal, such as hikikomori and other forms. So, as you can see, it's a very wide set of intervention that they were all targeting differently this transdiagnostic mechanism we were talking about. Even approaches such as CBT that maybe are not directly focusing on that, were in any case focusing on experiences such as trauma and so on. And the other were directly related to these five mechanisms. So, for example, even the work by Takahiro Kato and Hikikomori and so on were related to attachment and so on. So, in the way we try to discuss and put all the information together in the concluding chapter or discussing with many authors invited, Paul and I were hoping that this book would have served as a ground, as a basis for, let's say, fostering a more clinically oriented approach to schizotypy, and not just considering as, let's say, an interesting topic for research, but rather an important way to discuss even severe mental disorders in terms of potentially healthy threats that for the intertwined course of early negative experience, developmental problems, different characteristics may lead to these severe manifestations. And we also notice how sometimes we have wasted a lot of resources and looking for a sort of Sangval of psychopathology, that is the idea of finding the exact gene or the exact measures that will have explaining why people has this heightened risk without investing resources to the development of effective treatments. And it's quite strange, again, if we consider the prevalence, because as I was saying, let's say that an estimation formulated by Barrantes Vidal and Thomas Quapil, there were two authors of our book, suggests that, as I was saying, almost or just less than 10% of people in the general population who have this threat. And if you look at prevalence of the most representative diagnosis of schizotypy, that is schizotypal personality disorder, then you see that usually we consider a prevalence rate of about 4.6%. Again, the general population. So we are talking about of possibly 1 out of 10 persons having the risk of manifesting these disorders. And if you look at any website from American Psychiatric Association, American Psychological Association, and so on, where they report guidelines for treatments, you don't find a clear-cut suggestion about what to do. And for example, on schizotypal personality disorders, there are just one systematic review, one stopping review, and now the group that have realized the chapter on clinical stage in our book is working on another systematic review, but all this limited information confirms that almost nothing is available. So I'm happy to see how after the work on this book, other papers have been published on the clinical treatment of schizotypy. So I hope, and this was the hope of Paul too, that this book will have served as a sort of booster of research on this topic. So let's say that sometimes it seems that certain intuitions, certain ideas of forerunners such as Eric Sullivan sometimes seems to be forgotten. And so they were sometimes more brave than us in considering the importance of developing psychosocial treatment for people struggling with severe disorders. So before going on, because I have talked a lot, maybe too much. I don't know if you have any question or comment of what I have said, or always anything is not clear.
Well, I don't know if you're going to go into it a little more, but I'm curious in terms of just the different therapy approaches that were described, if what you saw as sort of key findings that distinguished one from another in their approaches to schizotypy.
Yeah, let's say that in the set of something like 11 chapter, if I remember well, on this topic, we have to say that there is not so much in terms of treatment specifically on the wider organization of personality. Let's say that we have published, I guess, the only randomized control trial of a psychosocial treatment for schizotypal personality disorders because there are only a few other studies, but more in terms of psychopharmacological treatment or integrated, let's say, good psychiatric management, such as the famous studies that have been published 30 years ago in Denmark. The other intervention were more focused on different topics. So, for example, metacognitive personal therapy has been focused on personality disorder widely. And so they have collected some evidence on cluster A personality disorders. And in the chapter by Giancarlo and colleagues, they were suggesting how to apply to schizotypal personality disorder. And similarly, the chapter by Carney, Ilanit, and so on, they were presenting the many evidence about merit for psychosis, and also suggesting extension to other manifestations of schizotypy. So these three treatment, the one I have been worked on, the one by Giancarlo and the group of Merit, are the one where the idea of considering the level of metacognitive functioning is the first kickstart, and then you whatever you offer that in accordance with the level of metacognition. On the other hand, there is the book on mentalization-based treatment that's on a certain level is similar, in the sense that, again, there is a focus on a general transdiagnostic factor related to a general functioning of the person or the personality. In this case, is defined as mentalization, that we know is not overlapping with metacognition, but there are several common areas, shared areas. Possibly there is a wider, greater focus on early experience and so attachment. But from my point of view, there is anyway a similar focus that can be shared, so a similar approach. Possibly let's say the two treatment that are more distant from this perspective are the one on CBT and the one on clinical staging. Let's say on CBT, the focus is, as usual in CBT, of working on beliefs and so how they affect the experience and may distort the experience, even if the protocol presented by Douglas Tarkington, that is CBT for psychosis, is widely focused on the role of traumatic experiences, and in this sense, it's quite different to me in respect to maybe first wave early attempt of use CBT. The chapter on clinical staging is more a way to organize evidence and what we know. So it's not properly a presentation of a treatment. They summarized what we know, and so they try an important attempt to me, that is to try to, if we consider it as a continuum, maybe we need, as they have done, I mean, the well-known work by Patrick McGorry on that, we need to define in terms of the level of severity of the manifestation, what works better and what not. Because, for example, now if we consider the greater evidence of merit in treating psychosis, and on the other hand, the greater evidence of metacognitive personal therapy on working on personality disorder, maybe we can use this information to clinical staging the different manifestation, or different way to integrate, or again, considering modular approaches to the treatment. There are finally two chapters that are mainly focused on psychoanalysis. That is the one by Andre Pack. He's a very complex paper, a complex chapter about how uh, psychoanalysis may inform and early conceptualizations of schizophrenia and psychosis and psychoanalysis may inform a modern approach to schizotypy, in the sense Andre Peck, his colleague, would focus on mechanisms that are a bit different respect to the other presented. So starting from the early works by Bion and Klein, and so they present a way to conceptualize early mechanisms related to standard conceptualization of schizoid mechanism and so on in psychoanalysis. Similarly, the work on Ikikomori by Takehiro Kato starts from a more psychoanalytic approach, even if in a more, let's say, modern fashion. And there is a difference in terms of a target of the intervention, that is the social withdrawal. So they have developed different ways to generate an early therapeutic alliance with client with severe social withdrawal, starting even from contact through social media and so on, and the use of family intervention with the idea that in this form of severe social withdrawal, important maintaining factors of the disorder are related to family dynamics, and so they involve the family in their treatment. So I don't know, Jay, if I have made it more confused than before, or I have added something clearer. I would say that the main idea by Paul and other Paul Lysaker and other scholar to focus on this general ability related to understanding one's own experience, inner and interpersonal, intersubjective experience, is possibly the more common factor mechanism that they all share. Even if we talk about CBT, that is for sure far away from these ideas, but if you read the description, the transcripts that Douglas Tarkington is presenting, basically he is focusing on that with a very different approach. But so I guess that in the concluding remarks, Paul and I formulated this metaphor that that is to consider schizotypy as a sort of disorder of engaging in the world. So the idea that you struggle to understand how to relate to the other, and you get confused, fragmented about your experience to the point of not having tools to relate yourself to the other, and this vicious cycle lead you to this severe manifestation. So all these different treatments try to target this main huge problem and try to offer alternative strategies, using my words, to cope with threats such as dealing with the others, or threats such as understanding one's own goals, scopes, and meanings. So I don't know if you have any other questions or comment.
I was curious about, and maybe you mentioned this before and I just missed it. I'd had to be in and out for a few things in the clinic, but I was wondering if in the chapter that you talked about like metacognition in this population, if there was like a typical metacognitive profile that has been seen, or if there just hasn't been enough research on that, or just kind of what your thoughts are about that.
Yeah, no, I didn't talk. Let's say it was one of the many papers Paul and I were thinking about. I have collected data, but I'm too lazy to publish everything. So maybe in the future I will publish. Now, what we have seen, because we have collected here at our clinics in Florence several mass A scoring of different sessions through 6 months of people being treated. And so comparing all the personality disorders versus schizotypal personality disorders. What we have seen is that there are two variables, two indicators that we have construed, discussing Paul and I, that is a general, let's say, fluctuation/variation. I'll try to explain what I'm meaning. Think about now a patient with a narcissistic personality disorder. He may have problem in the centration. He may have problem in understanding others as valuable and alternative point of view. This metacognitive problem is quite constant over time. So during the same session and among different sessions. When we compare these metacognitive profiles so other personality disorders and schizotypal, we found that we had a greater variation of metacognitive functioning within the same session and between different sessions. And the only other profile was a bit similar was patient diagnosis with borderline personality disorder with complex trauma, complex traumatic history, that were sometimes similar profile. So my initial hypothesis based on that, again, we have to publish the data, but is that the specificity of the profile is not that in terms, obviously, for sure, has any severe disorders. There can be problems of reflectivity, and maybe in other kind of disorder you don't find this kind of severity, problem in understanding basic issues in the other's mind and so on. But this kind of fluctuation is, to me, extremely important, and at least is consistent with my conceptualization schizotypal personality, that is an intertwined path between metacognitive functioning, so problem metacognitive functioning and problem in regulating the perceived threat for a more physiological level. So people may perceive the other, a gesture of the other, the therapy itself, as threatening, and this obviously may increase the defensive stance, and in turn this reduce the metacognitive level. We are trying to collect data on that. There is another project we are working on in terms of some psychophysiological measures during mass A, people with schizotypal personality disorder. And this would be consistent with what we know, that is, when we are under threat, we do have a vagally mediated response hypoactivating the prefrontal cortex. This would be consistent with the idea that when you are under threat, you have a reduced access to your metacognition. So my explanation of this fluctuation in those with schizotypal threats is that they may have, as they report in their narratives, a huge difficulty in struggling with interpersonal problem, interpersonal challenges. These represent a threat, and is very consistent with any definition of cluster A personality disorders. These represent a threat, not just metaphorically speaking, but also to them physically speaking. So think about someone diagnosed with paranoid personality disorder. The other is a threat. I have to be suspicious because you are a threat to me. And so the idea is that the difficult challenge in regulating the relationship, the therapeutic relationship, I mean, progressively reduce this fluctuation over time, but we have seen this difference. So again, coming back to the question by Kelsey, I don't know if I have answered to you, but not just in terms of which function, but in terms of general fluctuation.
No, that was definitely helpful. Thank you.
Let's say that, unluckily, Kylie is not here, but in chapter 4, Kylie presented a very amazing, I like tables, I have to say, a very interesting table summarizing all we know in terms of deficit in social skill, cognitive skills, and anticipated pleasure, emotional regulation, and so on. And so they summarize a lot of evidence about this. Is a profile not mostly in terms of metacognitive functioning, but let's say more emotional and cognitive skills. And my interpretation, I don't know if Kylie would agree with that, but my interpretation is that all this evidence relates to difficulty and connecting in social situation, difficulty in understanding the other's mind, difficulty in regulating positive feelings such as pleasure, negative feelings such as negative response, and so on, that increase this difficulty. So we all have this problem that when we are under threat, we don't work so much. I use this metaphor with the clients. That is, if you want to see if I'm good in playing chess, you don't put me in a jail with a tiger, because usually when I'm surrounded by a tiger, I don't play chess so well. So this problem is quite common in anyone, but the evidence collected by authors such as Simon Miner and other is that they seem to have, people with this threat seem to have a greater difficulty in regulation when they have under threat. I mean, regulating all these different needed skills from social, cognitive, and so on. So my understanding, it's not my truth, but my understanding is that all these different information, evidence, and so on seems to be quite consistent with that. In two recent papers we have published, one on current psychology last year, 2 years ago, sorry, one on journal Nervous and Mental Diseases last year. We showed how those with high level of schizotypal threats were showing, on the one hand, a greater effect of self-criticism on insight, cognitive insight. We use a questionnaire to assessing metacognition through questionnaires is quite impossible, but so we use just a measure of cognitive insight. But we show how the greater are severe form of self-criticism, the less is the protective role of insight against delusional ideation. So if you have in this case an internal threat, such as I hate myself, such as people with, let's say, psychosis with a huge stigma related to that, I may attack myself internally, and this may lead me to a reduced capacity to use our metacognition. In another paper, we show how the relation between schizotypal threats and different psychosocial the forms of psychosocial distress were moderated by different kind of perceived threats related to internal threats against us, external threats such as socially prescribed perfectionism or fear of being helped by the other and so on. All these factors were related to schizotypal threats in the sense that dude with higher, greater schizotypal threats went under internal or external threat were showing significant distress. In both these cases, we collected large sample. First one was 1,000, second one 2,000. Healthy sample, but we use a moderation model to see the relation between these threats and these manifestations. So again, I think that not conclusive evidence, but quite encouraging evidence. Right? I don't know.
Yeah, I'm thinking back to Kelsey's question and your response about kind of metacognitive profiles and for folks with schizotypy and how they tend to fluctuate. Any thoughts as how that might be able to encapsulate it in a measurement methodology to measure fluctuations in metacognition over time or situational fluctuations? It's just so it's not stable. Metacognition isn't stable. It's just going to fluctuate based upon situational factors and things that are going on. Any thoughts about how we may be able to measure that?
Yeah, possibly, yes. And that's the reason why we compare, what we have is just a comparison between schizotypal personality disorders versus all the other personality disorders. What we have seen is that obviously all the profiles of all the diagnoses with PDs were showing fluctuation. The difference was found in terms of those with SPD, schizotypal personality disorder, were reporting a greater and more recurring fluctuation, both within a session and between session. So again, I see. I have in mind the comparison I was making because I guess it's clear now. If you think about a profile of a client diagnosis with narcissistic or obsessive compulsive personality disorder, they do have metacognitive impairments. These impairments may be greater or smaller depending on the problem or the moment, also the interaction and so on. But usually, for example, they have a sort of constancy in certain difficulties. What has always surprised me, and that's the reason why we started with this study, is that people with schizotypal personality disorders, you really pass in 1 hour from a good capacity to the center, good capacity and interest in understanding therapist's mind, and then considering the other has a threat, even a physical threat, with a certain paranoid stance. And these huge changes are, again, it's my hypothesis, we have just an initial sample of 30, 34, 33, I don't remember, patients, but this fluctuation is greater than in other disorders. We analyzed the transcript, not we didn't. We used the Indiana psychiatric interview at the beginning and the end, but the comparison was made by analyzing the transcript of the sessions one by one. just to add this final issue, when we saw this variable, this measure related to threatening beliefs, we looked for a confirmation, seeing if these moderators were working also with other personality traits. What we found again is quite similar to what I was saying before, that is, they were moderator to all the tracks except for antagonism. We were using AMPD model, but the level of the moderation, the explained variance was extremely lower than for schizotypal traits. So again, I think that this intertwined path between perceived threats and metacognitive impairments is common, and you can find it in all the personality traits, but in schizotypal traits, they have a greater impact in terms of psychosocial distress. So in this sense, I guess a main conclusion of the book Paul and I edited is it's important in any case, in any kind of therapy, to work on that. But if you want to work with someone with schizotypal traits, you have to start from that. I remember a client that I treated with merit and was supervised by Paul, that she passed the first 2 months of the therapy just yellowing against me. She had unlikely, reasonably, reasons for hating males. And so she was possibly having a relational test with me, seeing if I was accepting the fact that she may have attacked me and then work on her distress. So basically, Paul and I, Paul as my supervisor, accepted that she passed the first 2 months yellowing against me. And then after that, we started working a bit on metacognition. So I don't know if you have another question or comment.
This is not a question, but a comment. I just wanted to say thank you for a really interesting talk and for all the good discussion that we've been able to have. Obviously, there's still plenty of time for more questions or comments that people have, but wanted to put that out there as well.
All right, thanks. Put it here if you want is the link on Springer website. There are a few chapters that are free to be downloaded, especially the introductory chapter and conclusive chapter by Paul and I. Then there is nice foreword by Robert Kruger.
Well, you mentioned a paper that you had some idea about. I'm curious though, just like what the next steps are in your mind, or where you think this goes next.
Again, we have we are trying to collect more evidence of clinical samples, because the initial formulation of the conceptualization has been made on large studies, so large sample to even 2,000 people and so on, but non-clinical. From my point of view, this is not necessarily a weakness, in the sense that if we support an idea of a continuum, of personality traits from healthy to maladaptive manifestation. It's good, but we need more data on clinical samples. So we are now trying to better work on this transcript and so on with mass A, and then we are working on another RCT on to confirm that it works. It should be out, I hope, in a few weeks. A case series on paranoid personality disorder. Let's say my interest has always been in integrating the work by Paul, metacognition, with an evolutionary perspective, and to me is an extremely fertile area of thinking and research, and I use that to inform more, let's say, research-oriented studies, and also my shared conceptualization with the client, in the sense that I try, when talking with clients, using obviously simple words, not jargon and so on, but I try to explain what I was presenting at the beginning. So the idea that I'm truly convinced that these are wide organization personality. So there is a continuum. So this implied that people are not wrong, their traits are not wrong, and so it's just a missing adaptation. And so what we want to help them is to recover, restore the uniqueness and the meaningfulness of their traits. So not this is a bad trait, you have to let it disappear or cover or hide, but rather let's try a way to value it and to use it in your daily life. No, so that's the reason why I like a lot the integration between metacognition and evolutionary theory, at least to me. You don't necessarily like. So there is an interesting evolutionary study on genetics that show how Paul liked a lot this paper when I mentioned him, because basically they found that in large study, if we know that we all have a genetic admixture of Neanderthal. The interesting issue is that the greater is this Neanderthal admixture in your genetics, the smaller is the risk you have to manifest schizophrenia. And if you manifest schizophrenia, you will have less severe symptoms. So this study basically suggests that possibly that these severe mental disorders are related to our uniqueness as humans, such as metacognition. So possibly these disorders we are talking about are to a certain extent and a sort of unavoidable risk when you have to cope with a complex function such as metacognition. So basically, psychotherapy should be aimed to help people to find a way to cope with this crazy recent machine that we call human brain. With clients, sometimes I use the metaphor of giving a Ferrari to a teenager. It can happen that they may have problem in driving a Ferrari, no? So driving our complex prefrontal cortex, complex metacognition, it's very difficult. We can expect that people may have difficulties. Okay, so I don't know if there are any questions, otherwise.
Yeah, what was that study you just mentioned? The evolutionary one?
The last one about genetics of
Yeah.
Neanderthals.
Yeah.
Yeah, I have to, yes. Let me see if I can find easily. There are two papers. One is this one, I guess, if I remember well.
Other questions or comments that people have before we finish off today? Alrighty, well, guess we can end a few minutes early. I saw you unmute yourself, Reed. Did you have a comment?
No, I was just ready to sign off and thank Simone for his
Oh.
presentation.
Okay, perfect. You read my mind.
Okay, thanks you all.
Thanks, everybody.
Yeah, thank you, Simone.
Thank you, Simone.
Thanks, Simona.
Bye bye.